This video, like most of my videos, is mostly for me, I guess, but if it helps somebody else, then that's great. I just like to watch these later, potentially when I'm in clinicals. So it's mostly for people that are planning on becoming physicians and just learning the drug names. This is in no way intended for patients or anything, just learning tools and just silly and simple mnemonics to help remember. And this one, I'm just going to be covering 6 of the oral therapies for diabetes because those 6 are going to be the most high yield. There are a few others, but I will just be talking about the main 6 that we use. So first off, I divide them into 2 groups. 3 affect the pancreas and 3 don't affect the pancreas. So on your papers at home, just draw a line down the middle. Oh my goodness, that is not a straight line. There we go. And on the left, we'll do ones that affect the pancreas. And on the right, those that don't affect the pancreas. And the 3 drugs classes that affect the pancreas are sulfonylureas, which most you can abbreviate that as SU. I'm going to write it out though. So sulfonylureas is SU, and then we've got our glucagon-like peptide 1 receptor agonist, but I just wrote GLP-1, and then DDP4i. And how I remember these is, this one is good-looking pancreas. So obviously that one affects the pancreas. And this one is dump and pump pancreas. Normally we say pump and dump as in breastfeeding, like if for some reason you were pumping the breast milk and then instead of using it you dumped it. So I just think of like milking the pancreas, and that's essentially what this does, is it tries to get the pancreas to be more active. But anyway, so let's talk about each one of these and how they affect the pancreas. So this one, it just increases beta activity. Both of these work in very similar ways. This one is literally just giving you the protein that stimulates the pancreas, and that's this glucagon-like peptide. This one prevents the breakdown of that protein. So either way, you're ending up with more glucagon-like peptide, and glucagon-like peptide is a type of incretin. That's the category of proteins that it belongs to. So you'll see DPP4Is. You'll see it explain that they prevent the breakdown of incretin, and GLP-1 is a type of incretin. So these will increase beta activity. But the end result of increased incretin or increased glucagon-like peptide is stimulation of the pancreas at the beta cells, but inhibition at the alpha cells. So increase beta, decrease alpha, increase beta, decrease alpha. Interestingly enough, if you care, these were discovered in 2005. That will become important because that means that it will be off patent in 2025, so these will become way more popular when we have generics on board. But anyway, when they figured out that this worked, somebody had the idea to shift their focus just a little bit to just incretin in general, and then that's how they came up with the DPP4Is. So they were like, oh, okay, we can give them the glucagon-like peptide just straight out, and that worked really well. So how about let's just prevent the breakdown of GLP-1. And so the very next year they came out with this one. So, yeah. And then, so how do we remember these names? Sulfonylureas, I think of cell phone urea. So basically, this cell phone is constantly calling your pancreas to pee beta activity, which is insulin, peeing insulin. So cell phone, like sulfon, and then urea, constantly peeing insulin. So that's how sulfonylureas work. They end in "ide." Glyburide is the only one that I ever remember, and that's because Glyburide, the end almost sounds like bride. Glyburide. And this is the only one that's approved in pregnancy. So as a general rule, they say that if you are diabetic in pregnancy, whether that's gestational type 1 or type 2, doesn't matter, you have to use insulin. But this is actually approved also in pregnancy, although it's not recommended, because as you know, the way this works is by stimulating the pancreas constantly. And the reason that blood sugar control can be difficult in pregnancy is because there's a constant release of a hormone by the fetus that breaks down insulin. And that helps the fetus because that increases blood sugar, so the fetus has more access to more blood sugar. However, for the mom, that can be taxing on the pancreas. And so already you have a fetus that's taxing the pancreas. And then you add this medication, which just increases the burden on the pancreas to produce more insulin. So, but you can use it. And another thing with sulfonylureas, because of this constant calling, this cell phone ureas, it will typically become ineffective after about 2 years. So it does make a lot of sense in a 9-month period. It should work just fine. Shouldn't cause any problems. There's no risk of pancreatitis, unlike these two, which do carry a risk of pancreatitis. And because there's no like fluctuating. These two, it fluctuates with blood sugar, which is more natural, but this one is not very natural. It's the only one that carries the risk of hypoglycemia. The only one of any of these oral therapies or any of the other lesser used. This is the only one that carries that hypoglycemic risk because it doesn't matter what you ate. It doesn't matter if you don't eat at all. It's constantly releasing insulin. So that's a big thing to look out for with the sulfonylureas. That's a big reason why they don't like using it in pregnancy. But other than that, it does work pretty well. The other big thing with this one is it can cause weight gain because of this constant insulin release. And this one's been around for quite a while. It's way far down on the totem pole for stuff you're going to use because it comes with the hypoglycemic risk. And that can be dangerous, especially in older folks. It can worsen dementia, which is a really big concern. So, however, but when we did use it more often, there is a problem with sulfa allergies. About 3% of the population is allergic to sulfa, so that means you can't have sulfonylureas, you can't have furosemide, which is Lasix, a diuretic. You can't have Bactrim, which is sulfamethoxazole, partly. So that's 3% are allergic to sulfa. And so what was I saying? So the allergic patients had no other options. Like we had metformin and then we had this. And so then they came out with semaglutinide. It's under the class glutinide. You'll see it written GN. But I didn't even bother listing that here. But basically that was used as an alternative if you had a sulfa allergy. But like I said, I'm not going over all of them because you'll never see that used really. That one does have the benefit of actually being glucose dependent, so it will not constantly call on the pancreas to release insulin from beta cells. It will actually do that based on your blood sugar levels. So semaglutinide, it works a little bit better I'm not sure why we don't use it instead of sulfonylureas. Probably it just never became that popular because we have so many other options. And sulfonylurea is very, very cheap. So that's another benefit to sulfonylureas. So in conclusion to this tangent on sulfonylureas, it's a cell phone that constantly causing your pancreas to secrete insulin. It can cause hypoglycemia because it's just a constant release. It can cause weight gain because of that constant release. And it can the one oral therapy that's available in pregnancy. And typically what happens in pregnancy, especially with gestational diabetes, is you say, okay, you have diabetes, they want to do insulin, and then they can't use needles because they've never had diabetes, they've never used insulin or even thought about using insulin. Then this is an option, Glyburide, for pregnancy. And after 2 years, these typically no longer work. Okay, now, good-looking pancreas, glucagon-like peptide, essentially glucagon, but if you give the body glucagon, it will recognize that, and then the body is pretty good about being lazy, so if you give it anything artificial, it'll just stop making it naturally. So you give the body testosterone, it'll stop making testosterone. If you give the body steroids, corticosteroids, it'll stop making cortisol. If you give it glucagon, it'll stop making glucagon. So it sounds a little counterintuitive, but it actually works. And so it actually will stop the production of the alpha cells, increase the production of beta cells, and the insulin release. And what else about, oh, so like what kind of endings does it end in? So this ended in "ide." This one ends in glutide. And so I think of that like, it ends in, glutide. And so that almost kind of sounds like GLP-tide. So I think of it as like a tidal wave of GLP. And so that makes it raining beta men. Because, like raining men is like a tidal wave, and it increases the beta activity, not the alpha. So not alpha men, but beta men. And so that's how that works. The most popular one probably in this one is liraglutide. Liraglutide is also approved for weight loss. So not just for diabetics, if you just want to lose weight. I'm honestly surprised this hasn't caught on as a black market drug for models, because diabetics, if you have really good insurance, you can get this drug pretty easily. It's a first-line drug. And I know most people think metformin is first-line, and it is, but so is this one. So you can get liraglutide, and then you could sell it to models to help them lose weight. But as far as I know, that's not happening. But that's how I kind of think of liraglutide. Like you're leering, like you're like, what's going on with this drug that's making everyone so skinny? I don't know. So that is, I think, everything I wanted to say about this one. A weird side effect of this one, I don't know why this is. It doesn't make sense to me, but thyroid cancer is a contraindication. So specifically medullary thyroid cancer, which actually it's not really common. Papillary thyroid cancer is going to be much, much more common, but if you happen to get the more rare medullary thyroid cancer, you cannot have this drug. I'm assuming this glucagon inadvertently also stimulates the thyroid, and therefore, if you had a cancerous thyroid, that would reignite the cancer. This is kind of like my thought process, although I'm not really sure how they correlate. Medullary thyroid cancer is mostly caused by MEN2 syndrome, both MEN2A and MEN2B. So, in fact, if you had that syndrome, it's an autosomal dominant syndrome, then you would have to have your thyroid prophylactically removed before you were even diagnosed with cancer. If you had that genetic mutation, you would have it removed, and then you would not take this drug. Even if you did have your thyroid removed, there's still the possibility that you had thyroid cancer cells somewhere in there, and taking this drug could ignite that cancer. So that is GLPs. good-looking pancreas. It affects the pancreas. Glutide is like a GLP tidal wave. It's raining beta men. Now, DDP4i, I think of dump and pump pancreas. It works pretty much the same way. It increases alpha, decreases beta. And it's incredible because it reduces the breakdown of incretin. So you have more incretin around. And GLP-1 is a type of incretin. And it ends in gliptin, which that sounds like a GLP twin, because essentially it copycatted the action of GLP-1 in its creation. They just figured out GLP-1 works, then they figured out a little bit further, or a little bit before that, to prevent the breakdown of GLP-1. And so that's a gliptin is GLP twin, because it copycatted this one. Because this came out in 2005, this came out in 2006. And this one is not first line though. There's a lot of, this one has had a lot more studies done, showed a lot more cardioprotective benefits with this one. And then the DDP4Is is actually, there's one drug that actually has shown an increased heart failure hospitalization risk. So that's weird that it would work that way. I don't know if it's because that's just, it increases all types of incretin, not just GLP-1. I'm not sure. But this one, very good looking pancreas. This one, I mean, I say it's incredible, but it's not that incredible once we got these clinical trials looking at the different cardiovascular effects. Now, it's fine to use. And another thing to point out about these two is if you're taking a GLP-1, you cannot take a DDP4i and vice versa because they work so similarly. They're working on the same pathway. So you would not take both together. And if one failed, the other one is also going to fail. If your A1C is not dropping, then your A1C is not, like, you're not going to get any better control from one or the other. You might get a more cardiovascular benefit from this one, but if you had some sort of side effect from this one, like maybe you were losing too much weight and you didn't want to lose weight for whatever reason, you could use the DDP4i, which is weight neutral. And this one makes you gain weight, this one makes you lose weight, this one is weight neutral. So that would be a reason to use a DDP4i instead of a GLP-1 is just based on side effects. But there's no benefit to GLP-1 is definitely going to be preferred over DDP4i. Okay, so that was a long history lesson. Now we're going to go on to the things that do affect the pancreas. First, obviously, being metformin. Those are biguanides. And so biguanides is big. And so I think of a big iguana has a big liver. And this is my iguana on the liver, I guess. Big iguanas have big livers, and it prevents gluconeogenesis, and it can have some mild weight loss, so that's really good. And the biggest thing with this one is that it tends to cause GI issues. That's going to be the biggest reason people stop taking it. And in that case, you could then go to a GLP-1. And this one's been around for a really long time. It's very cheap. Actually, if you get diagnosed with diabetes, the American Diabetes Association recommends metformin just off the bat, just right away, as soon as you get diagnosed. If you meet any of those criteria, usually an A1C greater than 6.5, then you are immediately given metformin. Other guidelines say, you don't have to give them any kind of medication until they're over 7% A1C. So you can decide. So with metformin, there's really no fallback to metformin other than the GI issues. You can lose a little bit of weight. It's really, really cheap. And most people just do it kind of de facto. If you're diagnosed with diabetes, you get metformin. Some people wait until you're above 7%, and that's really up to you and your patient. First line treatment obviously is going to be diet and lifestyle modification, and then metformin is going to be second line or first line pharmacotherapy. And the next one is TZDs, thiazolizidinides or something like that. And the last one is SGLT2 inhibitors. I know it's very long, and we'll talk about that later. And so TZDs, it kind of sounds like EZD, and EZD, I think of EZD as like that's a strip club, and these end in glitazone, so that sounds like glitter zone. And as we know, the glitter zone in the body, or in the strip club, is on the body, like from body glitter. So this affects the whole body by increasing the sensitivity to insulin. So that's how I kind of put all that together. TZDs, and then glitazone, and glitter zone is on the body, so it affects the body. The biggest thing to know about this one is that it's contra. Can I help you?
I'm so sorry. I just wanted to tell you how much I love you.
I love you. The biggest thing to know about TZDs is that it is contraindicated in heart failure. That's the number one thing to remember. And also, you have to constantly check a liver function test to make sure that that's working okay. And so how I put that together in my mind is I think, okay, TZD is like going to a strip club, and it's affecting the whole body, and then glitazone. And like at the strip club, you drink a lot, so you want to check to make sure that their liver is okay continuously. If they're on this drug, you need to be constantly monitoring their liver function tests and making sure that they don't have heart failure from all that drinking, I guess. And the other weird thing is bladder cancer is a risk, and so the only reason that would come into play is if they were maybe a smoker in the past, and or they had a family history of bladder cancer, then you might consider not using this. And at the very least, you should tell them that that's a possibility. I mean, if they had a family history, I would not do it. I would not use this if they had a family history of bladder cancer. If they were a smoker, it would depend on how long they smoked and how long ago it was that they smoked. But other than that, and if they had ever had any kind of hematuria, that would just freak me out, and I just wouldn't do it. But that's something that they don't stress at all in the textbooks or anything, but they just kind of list it randomly as a side effect as bladder cancer. And for me, that's really scary, and those are the sorts of things that I'm thinking about. In practice, I guarantee you most people never think about it, but they mostly think about heart failure and checking the liver function for TZDs. Now, basically the only TZD that is really used is pioglitazone, and that's because another TZD was actually recalled temporarily. Probably was not warranted, obviously, because it's back on the market. But that's why we no longer use it in heart failure, because this other drug had potential negative effects within heart failure. But pioglitazone actually has shown a benefit as potentially preventing stroke. So, especially if they have a history of stroke, then TZD is actually a really good idea. So that's on TZD, though, the other drawback is the weight gain. So it's another one of those that can cause weight. If you want to rank it, insulin's going to cause the most weight gain, and not that much. It actually, on average, only causes about a 10-pound weight gain in 3 years for insulin, on average. So that's not, I mean, if a patient's like, oh, I don't want to use insulin, that'll cause me to gain weight, and then you tell them 10 pounds in 3 years, that might not be as much of an issue. And so insulin's going to cause you the most weight gain, followed by sulfonylureas, cause the second most weight gain. I don't know what it is, but it's less than 10 pounds. And then TZDs are then on the next tier. They cause the least amount of weight gain, but still a statistically significant increase in weight. And that's it. None of the other drugs will cause weight gain, and in fact, a lot of them will cause weight loss. So, like GLP-1 causes weight loss. So, that was TZDs. Now, SGLT2Is, this one I get really creative with. And let's see if I can accurately show what I think about when I think about this. So we've got the glomerulus, right? And then we've got the proximal convoluted tubule, and we've got the loop of Henle, and we've got the distal convoluted tubule, and then we've got the collecting duct. And what does that spell? S G L T. Okay, so that stands for sodium glucose linked transport 2 inhibitor. So this is just a sodium glucose linked transporter, and the 2 is the predominant type in the nephron, and so it prevents your kidneys from uptaking glucose, because glucose is freely filtered in the glomerulus, as we know, and then your kidney has to work to reabsorb all of that glucose, and it does that by trading that with sodium. But if you just plug that transporter up with this drug, this inhibitor, then it can't do that, and you just flush out all of that sugar. Now, the biggest thing with these is going to be if you have such a sugary urine, you're going to increase your risk of UTIs, and this is even true in males. You can end up with UTIs. And also dehydration, because you're losing a lot of solute, it's going to take water with it. And so dehydration and UTIs is going to be a constant battle with these, and people are going to have to drink more water to prevent the UTIs, and they're going to pee more because of just the basic mechanism of action and having to prevent dehydration. So they're going to kind of have to, your whole life it's a big quality of life thing to try and figure out how to be near a bathroom all the time. So that's kind of the drawback with these, but they do cause a little bit of weight loss, and so that's good. And they're actually, since they take away that burden on the kidney of reabsorbing glucose, it's actually good in kidney disease. This is actually for diabetic kidney disease, which is super common. 1/3 of diabetics will have diabetic kidney disease. This is going to be actually your first line that you want to choose because it helps, it reduces albuminuria, and it takes that burden off the kidney of having to reabsorb all the sugar that most diabetics have in their blood. So that was counterintuitive to me at first, because I thought, oh, if it's acting on the kidney, then it's bad for kidney disease. But actually it's good as long as their GFR is at least 45. So if you know the staging, then that would be chronic kidney disease stage 3B is bad. You can't do it then. But if they have chronic kidney disease stage 3A, then it's okay. So 3B and below, you cannot use these because I actually don't know why, but I'm assuming like the nephrons are just bad enough at that point that this isn't going to be very effective or potentially harmful. I'm not sure. Now, so SGLTs, what do they end in? They end in flozin, and so I think of like glucose flows in. It ends in glyflozin, so like glucose flows in. It flows in and it never comes back out, and it just flows and goes into the urine. So that's flozin, glyflozin. The glucose flows in to the bladder, and so that is it. These came out in 2013, so it's going to be a long time before these are generic. Like I said, this is 2005 and 2006, so their generics are coming up pretty soon. So as far as first-line therapies, traditionally this is going to be first-line, but these two have actually been shown to be just as effective as first-line monotherapies. And this one you would use if there was any kind of arterial disease, and this one you would use if there's any kind of kidney disease. I will talk more about how to walk through the different options, but for now, this is kind of how I think about the different classes for oral therapies and diabetic management. Like I said, the alternatives to sulfonylureas, if you had a sulfa allergy, is glitinides or the drug named medullary. I haven't talked about the drug names, just the endings really, and this one, the main one is liraglutide. The main one here is pioglitazone. The main one with SGLT2is. Actually, there's several depending on what goal you're looking for, because they've had different clinical trial outcomes that have shown benefits with like kidney disease versus heart failure. And this one, like I said, reduces stroke, but is contraindicated in heart failure. And I'm probably just rambling. I will talk about the name brands, because these three are obviously still name brands. These three, let's just draw a line here. These three are very cheap, very generic, been around a long time. These three, pretty expensive. They rival insulin actually in cost, but there are programs that you have to apply for and stuff to make it more affordable, or hopefully if your insurance were to cover it. And these are going to be coming out in generic soon enough, so that's promising. But for now, these are cheap, these are expensive, and that's all I am going to talk about in this episode. Stay tuned next episode to talk about how to walk through the diabetic treatment pathway.